Hey everyone, and welcome to this explainer. Today, we've got a seriously vital clinical summary lined up, specifically for all the medical students joining us. We're going to unpack a hidden clinical threat that you are, without a doubt, gonna encounter in your future practice: visceral adiposity and the chronic inflammation it triggers. You know, what if I told you that the absolute most dangerous fat in your patient's body isn't the subcutaneous fat you can clearly see or feel on a physical exam? Nope, there's actually a silent, hormonally active fat depot growing deep inside millions of patients who otherwise appear totally healthy. Understanding this, it's going to fundamentally change how you evaluate patient risk. Okay, let's dive into this structured roadmap so we can really understand this active endocrine organ. Here's our agenda. Number 1, the TOFI phenotype. 2, pathophysiology. 3, systemic cascades. 4, etiology. And finally, 5, clinical management. All right, section 1, the TOFI phenotype, diagnostic illusions in clinical practice. Imagine you've got 2 patients sitting in your clinic right now. One has a high BMI and is visibly overweight. The other one is lean. So which one has the better metabolic profile? Well, researchers continually find that what we see on the outside is actually a pretty terrible proxy for metabolic health. That lean patient might actually be harboring highly dangerous ectopic fat depots, putting them at way higher risk than the visibly overweight patient. We really have to rethink relying solely on the bathroom scale or a quick visual check during intake. And this brilliantly illustrates exactly what we're talking about. We're dealing with 2 very distinct types of abdominal fat here. On the left, we've got subcutaneous fat. That's the superficial, relatively benign layer right under the skin. But on the right, that's visceral fat. It lives deep within the peritoneal cavity. And because visceral fat drains directly into the portal vein, it literally wraps your critical organs, like the liver, the pancreas, and the intestines, in this highly reactive inflammatory blanket. Which brings us to a really crucial clinical phenotype, TOFI. That stands for thin outside, fat inside. There are millions of adults walking around with a completely normal BMI who fall right into this category. Their outward appearance is basically masking a highly compromised metabolic state. They're silently developing issues like insulin resistance, dyslipidemia, and non-alcoholic fatty liver disease, entirely undetected by a standard visual physical exam. Section 2, pathophysiology, the endocrine function of adipose tissue. Now, what's really interesting about this slide is that it forces us to completely reframe how we view visceral fat. It is definitely not just some inert storage locker for extra calories. It's actually a highly active chemical factory. Hypertrophied visceral adipocytes and infiltrating macrophages are constantly pumping out pro-inflammatory cytokines, specifically things like TNF-alpha and interleukin-6, right into the systemic circulation. This keeps the patient's entire immune system in this constant low-level state of sterile inflammation. Let's actually walk through exactly how this pathophysiological cascade plays out over time. Step 1, visceral fat accumulates and tightly wraps those organs. Step 2, we get that constant active release of cytokines and adipokines. Step 3, systemic, chronic, low-grade inflammation sets up shop. And finally, step 4, all those inflammatory markers irritate the blood vessels, causing endothelial dysfunction and vascular stiffness. It's this quiet, simmering process that, over years, drives cardiovascular remodeling and totally wrecks insulin signaling. Section 3, systemic inflammatory cascades, hepatic, metabolic, and cognitive damage. Now let's zoom out a bit. Because visceral fat drains directly into the portal circulation, it essentially dumps massive amounts of free fatty acids straight into the liver. The liver just gets completely overwhelmed, which drives hepatic steatosis, or fatty liver. And then that lipotoxicity spreads. The pancreas starts struggling under the metabolic load, which leads to beta cell dysfunction. Consequently, blood glucose levels rise, and this whole pipeline eventually culminates in profound insulin resistance and full-blown type 2 diabetes. But the damage isn't just confined to the body's periphery. Those pro-inflammatory cytokines actually cross the blood-brain barrier, triggering neuroinflammation. Emerging clinical research is showing a really strong, terrifying correlation between excess visceral fat and reduced gray matter volume in the brain. Basically, this localized belly fat is actively accelerating cognitive decline and boosting the risk of neurodegenerative diseases. It's literally aging the brain. Section 4, etiology, the modern drivers of visceral adiposity. So how do we get here? Well, our modern environment is practically engineered to feed this hidden fat. There are four main culprits we see every day. First, ultra-processed foods and refined carbs cause massive insulin spikes, signaling the body to store fat deep inside. Second, chronic psychological stress overactivates the HPA axis, and that resulting flood of high cortisol directly promotes visceral fat accumulation. Third, poor sleep totally disrupts hunger hormones like leptin and ghrelin. And lastly, plain old physical inactivity shunts all that surplus energy right into those visceral depots around the organs.
Section 5, Evidence-Based Clinical Management, Reversing the Cascade.
So the crucial point is this. As dangerous as visceral fat is, the incredibly optimistic clinical reality is that it's highly metabolically active. That means it's exceptionally responsive to lifestyle interventions. Consistent aerobic exercise is your frontline treatment here. Pair that movement with protein-dense meals to keep patients full and preserve their lean mass. Also, they absolutely must prioritize 7 to 9 hours of sleep to get those hormones in check and use stress management techniques to actively lower cortisol. Consistent habit building easily beats out extreme short-term diets every single time. Listen, if you take one clinical pearl from this, let it be this. Aerobic exercise preferentially mobilizes visceral fat. A patient's metabolic markers and systemic inflammation can dramatically, undeniably improve well before you see any major drop in their overall BMI. You've got to communicate this to your patients early and often. If you don't, they might abandon these life-saving interventions simply because the numbers on the bathroom scale haven't budged yet. Your weight tells you how heavy you are. It doesn't tell you where your fat is stored. When it comes to metabolic health, location is quite literally everything. Gravity simply measures mass, right? It tells you absolutely nothing about the toxic endocrine activity happening right now deep inside the abdominal cavity. So I want to leave you with a bit of a provocative question to chew on. If your own body could show you exactly how much inflammatory visceral fat is tightly wrapped around your organs right now, would your daily habits change? Understanding this silent, hidden threat really is the first step to conquering it. Thank you so much for joining me for this explainer. I hope you're leaving here ready to evaluate your future patients through a much sharper, comprehensively metabolic lens. Keep learning, keep moving, and I'll see you